The final topic is going to be domestic minor sex trafficking, a Frontline Pediatrician's perspective, presented by Dr. Anish Raj. Anish was born and raised in Jacksonville, Florida. He completed his undergraduate degree at University of Florida and graduated from the Florida State University School of Medicine. He's currently enrolled in the triple board program at Brown University, where he's a PGY4. As an aside, I'll mention that this is my first time on the stage, and I'm a PGY 34, so his career is clearly on a different path than mine. Dr. Raj's career goals involve serving youth with trauma histories and enhancing awareness regarding sexual exploitation. So please welcome Dr. Anish Raj.
Good morning, ladies and gentlemen. Thank you all so much for being here, and thank you for this opportunity. It is an absolute honor for me to speak with you today about domestic minor sex trafficking and our role and responsibility as pediatricians in addressing this issue. I'd like to go ahead and confirm that I have no financial disclosures or other conflicts of interest. And because this is the national conference, we certainly do have a formal set of learning objectives. But what I hope that you get out of this is fairly simple. And that starts with an understanding of what is domestic minor sex trafficking, or DMST? Where is this happening? Who are these kids that it involves and affects? How can we help? And arguably, the unstated goal is to dispel some of the misconceptions that surround a topic of this magnitude. And the hope is that over the next 20 minutes or so, we'll be able to chip away at any discomfort so that we can all serve these children to the best of our abilities. Before we dive in, I'd like to perform a small mental exercise. What I'm going to do is flash a couple words up on the screen, and all that I ask is that you sit back and reflect and capture the first thoughts and images that pop into your mind associated with these words, and then we'll discuss. These words are teen prostitute and pimp, and I'll give you a few moments. Now, when I've done this exercise with healthcare providers in the past, the phrase teen prostitute typically conjures up the image of a girl wearing a short skirt on the side of the road, someone who looks like they're hustling, trying to get fast money. Interestingly, no one's ever told me that they pictured a boy. I'm curious if any of you did. On the other hand, the word pimp continues to be glamorized in our mainstream society. People typically picture a smooth-talking ladies' man wearing nice clothes and jewelry, driving a fancy car. Now, I'd like to do this one more time, but with a different set of words. And these are exploited child and exploiter or trafficker. And again, I'll give you a moment. Now, I don't like to assume, but I imagine that the immediate visceral reaction was different here than with the first set. The exploited or abused child is the patient that we all empathize with, the kid that we want to help as pediatricians, but also just as human beings. Conversely, the exploiter or trafficker is the prototypical bad guy, the creep, the person that we want to protect our children from. So I ask, isn't it time that we once and for all replace archaic terminology? Teen prostitute is a misnomer, and it's not just semantics. Words truly do influence how we respond to and provide care, especially when it comes to psychosocial issues. And to further reflect the paradigm shift that we need in our mindsets, here's a quote from Nicholas Kristof and Cheryl Wu Dunn, two New York Times journalists. They say, and I quote, "The basic problem is that we as a society look down on girls who have been trafficked. We see them on the street and they're wearing inappropriate clothing. They may be self-medicating with drugs or alcohol. They may be in love with their pimps. We are prepared to empathize with the girl who is chained to a radiator in a brothel, but we scorn a girl who runs away from police back to her pimp." All right, so let's lay a foundation by defining some words. The commercial sexual exploitation of children, or CSEC, is the overarching umbrella term that includes international and domestic minor sex trafficking, as well as numerous other forms of sexual exploitation. CSEC is broadly defined as any exchange of a sex act for goods, and goods can be money, shelter, drugs, anything of value, involving a minor, which we define as someone under the age of 18. Under CSEC, domestic minor sex trafficking, or DMST, is a subset. It more specifically refers to CSEC involving a US citizen or permanent resident within the borders of the United States. Those two qualifiers are what distinguish DMST from other forms of CSEC. And contrary to popular belief, trafficking does not require the movement or transportation of a victim. It's also important that we keep in mind that regardless of the terminology, sexual exploitation and trafficking are still bona fide forms of child abuse. Now let's dispel some myths. People typically envision trafficking as exclusively involving the smuggling of children into the United States from foreign countries like Thailand or India. And while this does happen, that usually reflects international or transnational trafficking. Numerous studies have determined that the vast majority of minor sex trafficking victims here in the United States are actually American kids. The Bureau of Justice estimates that this number is around 80%, and that constitutes DMST, making it the largest subset of CSEC. Another myth is one that's often sensationalized on television or in movies, and that's this idea that trafficking typically involves someone getting abducted and introduced to the sex industry. And again, while this does happen, it's actually relatively rare. It's far more common for traffickers or exploiters to psychologically manipulate their victims. There's also growing evidence that face-to-face interactions in social settings like at parties or in group homes can play a large role along with peer recruitment in initial recruitment. Another reality is that all genders are affected. Boys, girls, cis, trans, non-binary folks. While our society typically only portrays girls as victims, research shows that a significant number of boys are also being trafficked, but that we're not doing a great job of identifying them. Boys as victims of sexual violence typically fly under the radar. It's also important that we recognize that while most traffickers are indeed men, women can also play roles in exploitation. However, one area where there is a clear gender distinction is when it comes to demand or the buying of sex. Virtually all purchasers of sex are adult men. Again, virtually all purchasers of sex are adult men, and that stat speaks for itself. Now that we're all feeling a little unsettled, let's switch gears and talk about where we fit in as healthcare providers. Studies suggest that the vast majority of trafficking victims interface with the healthcare system in some capacity while being trafficked. Estimates peg this at upwards of 80%, so we know they're seeing us, but how good are we at seeing them? Unfortunately, not very. There's a disconnect in that about 3/4 of providers report not having been trained on this subject, and that's often the reason cited for why providers do not feel comfortable doing this work. Now, one of the things that most motivates me about this topic is when people come up and say, hey, does this really happen? I've gone my entire career without seeing it. And I worry that if this isn't on someone's radar, it could be getting missed. And I largely base that on the limited objective data that we have, but also want to provide an example from clinical experience. Back when I was a scrappy little intern, that's me, I spent 2 months down in the pediatric emergency department. That totaled about 35 shifts. I encountered 7 patients that I highly suspected to be involved in DMST. 5 of those 7 disclosed. Now, should we draw any conclusions or extrapolate anything from those numbers? Absolutely not. But I bring this up to hopefully help demystify all of this. There was nothing extraordinary about those encounters. There was no magic tricks up my sleeve. I think it just shows that basic awareness, comfort discussing this topic, and a low threshold to do so can go a long way. I came into residency with an academic interest in trafficking, and yet I was still surprised by how often I seem to come across it. Because at the end of the day, we really don't have good data on incidence or prevalence. However, what we do know is that cases have been reported throughout the United States. And the hope is that now that we recently secured ICD-10 codes related to human trafficking, and this is relatively hot off the press, we'll be able to do a better job of aggregating data and keeping tabs so that these kids don't fall through the cracks. Now, for everyone here, I wish I could provide you a sure shot, foolproof way of identifying someone who's being trafficked the moment that you lay eyes. But the truth is, there is no one set profile. Any child or adolescent is technically at risk. It doesn't matter where they live, rural, urban, suburban communities are all affected. It doesn't matter who their parents are or if they live in a group home. Victimization also transcends race, gender, sexual orientation. You may have noticed that this presentation contains fairly minimal images. That was on purpose, because I want us all to keep an open mind and not have tunnel vision. Because sure, it might be the kid in the short skirt, but it's more likely to be the kid wearing jeans who blends in with the rest of your waiting room. And what we can do here today is explore some of the underlying exposures and vulnerabilities that have been shown to be associated with DMST involvement. The strongest correlate that has been seen in study after study is a history of childhood sexual abuse. And I mean prior to being trafficked. We should all be aware of how childhood sexual abuse affects people long term, not only when it comes to their own self-image, but also with regards to boundaries and relationships with others. Next, we can look at background environmental factors. This usually implies some sort of household dysfunction. Families that are abusive, neglectful, maybe have their own substance abuse issues, as we just learned about, maybe have child welfare involvement. Youth homelessness is also a risk factor and leaves kids vulnerable. Another risk factor, as we alluded to earlier, is a kid's social circle, which can be deeply influential when it comes to peer recruitment. Now, the intersection point where a personal history of trauma and baseline household or social dysfunction can sometimes, but not always, meet is running away. A combination of intrinsic and extrinsic vulnerabilities coming together, if you will, and resulting in DMST involvement. But I do want to emphasize, a patient might have all or none of these risk factors and still be involved or not be involved. We honestly don't know enough yet to assume one way or the other. In our eagerness to identify, it's important that we don't start labeling kids, because that can be detrimental in a different way. Now, realistically, most patients don't present with the chief complaint of human trafficking, but there are subtle things that we can look for. For starters, are the clothing and accessories congruent with what you would expect from this patient? For example, if you have a patient that you know has historically struggled financially, but now is showing up with multiple phones, new $200 sneakers, new bags, it's probably worth asking about. Tattoos can be another clue. For what it's worth, most states require parental consent for individuals under the age of 18 to get a tattoo done in a professional shop. Now, I'd venture a guess that most of our kids with tattoos aren't getting them done professionally. So what's the significance of the tattoo? Is it a name? If so, whose name? Is it someone trying to brand what they deem to be their property? Is it gang affiliated? Things to think about. And then, of course, physical signs of abuse. These can manifest in any number of ways, but it's important to elucidate whether the explanation matches the expected mechanism of injury. So let's say that you have a kid that you're worried about. I think, like in all things in pediatrics, it comes down to rapport. Multiple qualitative surveys have looked at what survivors want from providers. And what's striking is that while we as providers tend to report discomfort due to a perceived lack of training, what kids want from us is actually fairly simple. They don't expect us to know the intricacies of the sex trade or life on the streets. They really just want us to treat them, well, like we treat all our other patients. And that starts with really listening and not simply labeling someone a victim. Encouraging them without resorting to you should paternalistic statements. Getting to understand their circumstances and why maybe they've made some of the decisions that they have. Not judging them, and this one's the biggie. Nothing has been reported to erode a patient's trust in their provider more than feeling judged. And last but certainly not least, sticking around. A lot of these kids have been failed again and again by adults in their life. Modulate your affect, be consistent, and don't give up. Even when they push back, stick around. So how might this play out in a clinical setting? So there is no script, so I'll take this with a grain of salt, but it's often analogous to how we all probably approach other difficult conversations. And that's by starting big picture and then following up with more direct, nuanced questions as we gather data and formulate a clinical picture. What's helpful is that the HEADS assessment or inventory that we've all been trained on actually yields quite a bit of relevant information. For example, we're already asking about home life. It doesn't take much to incorporate questions about running away, couch surfing, and the like. When we're discussing school, it's important not to gloss over how many days a kid might be missing, and especially if they're skipping. Where are they going? What are they doing? Who are they hanging with? From a financial standpoint, how do they pay for the things that they want to buy? Do they get an allowance at home? Do they have a secondary income? The remaining questions can also reveal relevant information, including but not limited to hobbies, drugs and alcohol, mental health, and safety and violence. I do want to make special mention of sexual health. Given the nature of the sex industry, this population is certainly at high risk for STIs, pregnancy, and complications. Baseline testing should include chlamydia, gonorrhea, trichomonas, syphilis, HIV, and hepatitis B and C, as well as pregnancy. If a patient is presenting with recurrent STIs, that can open the door to a conversation about exposures and sex practices. It's also important to assess vaccination status for HPV and hepatitis B. So let's say you pick up on some red flags from the head's inventory or physical exam. It can then be helpful to follow up with a more global discussion demonstrating that you know that things like trafficking are happening out in the community without putting the onus on the individual. Teenagers don't typically identify with the words victim or trafficking, but they might be more familiar with something like escorting. Broad setups like, I've heard from other kids, I know this is out there, can spark a conversation. The idea is to keep it open-ended, gently gauging what the patient can tell you about it. And then after you've developed rapport and feel like you fostered a safe space, you can then ask more direct questions about the patient's own experience. Word it how you feel comfortable, but some examples from the literature include something along the lines of, have you or any of your friends ever exchanged sex for something? The any of your friends part can again help take the onus off the individual, because even if that patient doesn't feel comfortable disclosing or isn't involved, if they're running with that crowd, it probably constitutes high risk as is. Other examples of questions include, has anyone ever asked you to have sex with someone else or made you have sex when you didn't want to? Or has anyone ever taken sexual pictures of you and posted them on the internet? But at the end of the day, securing a disclosure is not the goal. Studies suggest that most kids don't disclose, especially initially. So the goal should be to make a connection. Maybe a kid has blown off the 7 providers before you, but in you, they see someone that might just care, that might just do something. As one of my mentors likes to say, be someone that they can turn to, create an environment that they feel safe coming back to. Now, there are a lot of you here. Let's just be honest. There are a lot of you here, and I certainly don't know most of you. But I do feel confident in saying that this skill set is in our wheelhouse. This is what we do day in and day out as pediatricians and child advocates. But if you remember anything from this talk, please remember this. No one is asking you to do this on your own. That's simply not realistic. It takes a village. And the good news is that there's a lot of people out there that'd be willing to help and point you in the right direction. If you have access to child abuse pediatricians at your institution, they can be a wonderful resource. Every state has at least one sexual violence or sexual assault agency. The involvement of Child Protective Services varies from state to state when it comes to trafficking cases. So I would encourage you to check your state's laws, whether this falls under mandated reporting or not. But at minimum, Child Protective Services should be able to guide you on community resources. Your local police department can also be a fantastic partner, especially if they have a special victims unit. I know we've benefited tremendously from ours. The National Trafficking Hotline is a number that you can call and is available 24/7. And then, of course, our social work colleagues can often be important collaborators. As we do wrap up, I want to mention what comes up after initial identification. Unfortunately, the research isn't clear on what specific interventions work for this population. Recovery and reintegration into society usually has its ups and downs. But preliminary data suggests that 2 key components can be crucial, and those are addressing mental health and education. But it's not always straightforward. These kids can be complicated, and finding the right fit can be a challenge. You might have to get a little creative with closer follow-up and a more tailored trial and error approach instead of the standard clinic referral that we just hand out to patients. But it's worth it because improved mental health outcomes and an education can open the door to new opportunities. So in conclusion, let's keep trafficking on our differential radars while still recognizing that the key word in high-risk youth is still youth. Talk to them, get to know them. They're still kids, and our time and support as pediatricians can be valuable. Let's also make sure that our staff feels comfortable making this population feel safe. Kids don't just disclose or ask for help from their pediatricians. It could be the nurse, the child life specialist, the person on after-hours phone triage. And finally, let's take it upon ourselves to get to know the resources and services in our individual communities that address trafficking. Because again, we don't have to do it alone, but we do need to know who to turn to and ask for help. Thank you so much for your time.